You know those medical mysteries? The ones where a seemingly unrelated set of symptoms eventually points to something unexpected? Today, we're diving deep into one of those, Wilson's disease. It's a rare condition, yeah, but its impact on the body from the liver to the brain is, well, pretty significant.
Exactly. And think of this as your go-to audio guide for understanding Wilson's disease. We're going to break down what it is, why it happens, who's at risk, and the sort of chain reaction it sets off in the body. Our mission here is really to make this complex topic clear and hopefully memorable for you. We'll cover everything. Definition, differentials, how it's managed, the outlook, the whole picture.
Okay, perfect. So, Wilson's disease.
Right.
What's the headline definition we really need to grasp?
Okay, so at its core, Wilson's disease is a rare genetic disorder. And the problem is the body's struggling to get rid of copper properly. This leads to an abnormal buildup and accumulation of copper in tissues, particularly the liver and the brain. The key word is genetic. It's passed down through families.
Right, okay, genetic, a problem handling copper. So, what's the specific genetic glitch that causes this?
It's actually down to one specific gene,
Hmm.
the ATP7B gene. It's on chromosome 13. This gene is basically like the body's foreman for copper transport and metabolism. So when this foreman has a faulty blueprint because of mutations, the whole copper handling process just, well, breaks down.
Ah, so it's all down to this one gene, ATP7B. Now, who's more likely to have these mutations? Is there usually a family link?
Absolutely. The single biggest risk factor is having a family history of Wilson's. It's inherited in what we call an autosomal recessive pattern. Think of it like this. To actually have the condition, you need to inherit two copies of that faulty ATP7B gene, one from your mom, one from your dad.
Okay.
If you only get one copy, you're a carrier, but you typically won't show symptoms yourself. So yeah, both parents have to be carriers.
Got it. Takes two faulty copies, one from each parent. Okay, so let's trace how this copper overload actually, causes problems. What's the sequence of events inside the body?
All right, so the trouble really kicks off in the liver. That malfunctioning ATP7B protein means the liver can't properly package copper into bile to get it out of the body. So the copper starts to build up inside the liver cells. You can imagine the liver as a storage unit, and in Wilson's it just overflows.
Right.
Eventually the liver hits its capacity, and the excess copper spills out into the bloodstream.
Ah.
And this circulating copper then travels to other organs. The brain is a major target, unfortunately, and that leads to that whole range of neurological issues we see.
So the liver gets overwhelmed first, and then the copper basically goes on a damaging road trip, especially hitting the brain. Now, if someone presents with liver issues or some of those neurological signs, what else might doctors be thinking? What are the main lookalikes?
Yeah, that's where the differential diagnosis comes in, and it's crucial. For the liver side of things, you definitely think about other conditions causing liver cell damage, what we call hepatocellular dysfunction. So things like viral hepatitis, Hep A, B, C, alcoholic liver disease, obviously, and non-alcoholic fatty liver disease, and AFLD, which is linked to obesity and metabolic issues.
Okay.
It's really a process of ruling out those more common causes that might present with similar liver results.
Makes sense. Like detective work, ruling out the usual suspects first. Now, how rare is Wilson's disease? Are we talking incredibly uncommon?
In the UK, it's considered pretty rare, yeah. The estimates vary a bit, but it's around 1 in 30,000 people, maybe up to 1 in 100,000. It affects males and females equally. And the typical age symptoms start showing up is between 5 and 35, but most commonly it's between 10 and 25 years old.
And is there a pattern to who gets what symptoms when?
There's a bit of a pattern, yes. Often children tend to present more with the liver problems first, whereas young adults are perhaps more likely to develop the neurological symptoms initially.
Oh.
But it's important to remember it's still that same rare autosomal recessive disorder underneath.
And are there different sort of subtypes or ways it presents?
We sometimes talk about two main presentations, though it's a bit of a simplification. There's the so-called Slavic type, which tends to be later onset, maybe in adulthood, and is mainly neurological. And then the juvenile type showing up usually before age 16, and that's primarily affecting the liver. But again, the presentation can be really varied in reality.
Okay, so rare can wear different masks depending on age. What are the key clinical clues then? The sort of red flags that might make a doctor think, can this be Wilson's?
It's incredibly varied, that's the thing. It can hit the liver, the nervous system, mental health, even the eyes. So for the liver, you can have anything from just finding a slightly enlarged liver on exam, maybe no symptoms at all, right up to severe acute liver failure. You might also see signs of chronic hepatitis, ongoing inflammation, or cirrhosis, the scarring, or just generally severe chronic liver disease. And in some really serious cases, patients can get fulminant hepatic failure, which is a rapid, severe loss of liver function. Sometimes that even comes with hemolytic anemia, where red blood cells break down too quickly.
Wow, that sounds incredibly serious on the liver front. What about the brain and mental health side?
Psychiatric symptoms are actually quite common. They can include various mood disorders, behavioral problems. We often see significant depression, sometimes neurotic patterns developing. Neurologically, the real hallmark is movement disorders. Often it starts with an asymmetrical tremor, so worse on one side. And that tremor can be there at rest, when holding a position, or during movement. Early on, people might notice difficulty speaking clearly, dysarthria, maybe excessive salivation, clumsiness, or poor coordination, ataxia, and subtle personality shifts.
Right.
As it progresses, you can get more obvious issues. Involuntary jerky movements, poor form movements, problems with walking, worsening speech, and something called pseudobulbar palsy, which affects facial movement, speech, and swallowing.
And those distinctive eye signs we hear about, can't forget those.
Definitely not. The eye findings are a huge clue. Kaiser-Fleischer rings, those are the greenish gold or brownish rings you see around the edge of the colored part of the eye, the iris and cornea, they're present in up to 95% of patients with neurological symptoms. So a really important sign.
95%, wow.
Yeah. And then there are also sunflower cataracts. You can only see those with a special slit lamp exam by an ophthalmologist, and they don't usually affect vision. Less often you might get night blindness, a squint, inflammation of the optic nerve, optic neuritis, or paleness of the optic disc.
It's just amazing how copper building up can manifest in so many different body systems. Are there any other, perhaps less obvious symptoms that could point towards Wilson's?
Yes, the copper can deposit elsewhere too. In the kidneys, it can cause something called renal Fanconi syndrome.
Sure.
That can lead to things like too much calcium in the urine, hypercalciuria, or even kidney stones, nephrocalcinosis. Rheumatologically, you might see bone thinning, osteopenia, osteoarthritis, kneecap issues, chondroblacia patellae, calcium deposits in cartilage, chondrocalcinosis, or muscle weakness, myopathy.
Gosh.
The heart can be affected too, arrhythmias, irregular heartbeats, or a weak heart muscle, cardiomyopathy. And then less commonly, things like low parathyroid hormone, pancreatitis, infertility, even a bluish color at the base of the fingernails as your lunulae.
It truly sounds like a condition that requires putting pieces together from all over. And you mentioned the age of onset varies quite a bit.
That's right. The classic window is the teens and 20s, the second and third decades. But like we said, liver issues tend to pop up more in children and adolescents, while the neuropsychiatric stuff often emerges in young adults. But crucially, it can affect people younger or older than that typical range, and that's why you need a really high index of suspicion whenever you see unexplained liver problems, movement disorders, or psychiatric symptoms, really regardless of the patient's age.
Okay, so if a doctor does suspect Wilson's, what are the key investigations? What tests would they order, say here in the UK, to pin it down?
The diagnostic workup is usually a combination approach. You'll have blood tests, urine tests, genetic testing, and sometimes a liver biopsy or brain imaging. So blood tests measure serum ceruloplasmin, that's the main copper-carrying protein, and also total serum copper. A 24-hour urine collection is done to measure how much copper is being excreted. Genetic testing looks for those ATP7B mutations. If things are still a bit unclear, a liver biopsy can directly measure copper levels in the liver tissue. And an MRI scan of the brain can show characteristic changes if there are neurological symptoms.
Okay, let's break that down a bit more. What are the absolute must-do investigations here?
Right. Well, first off, that slit lamp eye examination by an ophthalmologist is essential to look for the Kaiser-Fleischer rings. Then, checking the serum ceruloplasmin level. Remember, it carries most of the copper, so in Wilson's, this level is usually low, typically less than 0.2 grams per liter, and often really low, below 0.1.
Okay, low ceruloplasmin.
Exactly. We also measure total serum copper, but maybe more importantly, we calculate the free serum copper, the copper not bound to ceruloplasmin, and that's usually increased. Then that 24-hour urine collection for copper excretion, that's another critical step. The amount of copper in the urine is often way up.
High urine copper.
Yeah. And finally, genetic testing for the ATP7B mutations gives you the definitive confirmation, if needed.
So it's really a combination, the physical signs like the rings, the biochemical markers in blood and urine, and maybe the genetics. When does the picture become pretty clear?
A diagnosis is really likely when you see that combination of clinical signs and lab tests pointing to abnormal copper metabolism. Finding Kaiser-Fleischer rings, plus a low serum ceruloplasmin, especially below that zero point 0.1 mark, is very, very suggestive.
Right.
Biochemically, that classic triad, low ceruloplasmin, high urinary copper, and high copper levels on a liver biopsy is strong evidence. Genetic testing is great for confirmation, but sometimes the clinical and biochemical picture is compelling enough, especially if genetic tests take time.
Yeah.
And certainly, having neurological symptoms and Kaiser-Fleischer rings is a big pointer. A liver biopsy becomes particularly useful if other tests are inconclusive or if there are major liver issues. An MRI can back things up by showing brain changes and maybe an ECG to check the heart. And crucially, screening first-degree relatives is vital. Siblings, children, they have a 1 in 4 or 25% risk, even if they feel fine.
Right. That screening is so important. So once Wilson's is diagnosed, what does treatment look like? Is it curable or is it about managing it?
Yeah, unfortunately, there's no cure right now. So management is all about lifelong treatment. The goal is to get the excess copper out and stop more from building up. The main treatment is copper chelation therapy. That uses drugs like D-penicillamine or trientine. They bind to the copper so the body can excrete it, usually in the urine.
Okay, chelation.
Exactly. Dietary changes help too, limiting copper-rich foods like liver, chocolate, nuts, shellfish. And regular medical follow-up is non-negotiable. You need to monitor how well treatment's working, check for side effects, make sure the patient's sticking with the plan.
Right.
Managing it during pregnancy needs a special approach, careful medication adjustment. Sometimes zinc acetate is preferred, then, as it's thought to be safer. And in severe cases, like acute liver failure or end-stage liver disease, a liver transplant might be the only option. For very specific refractory neurological symptoms, deep brain stimulation is sometimes considered.
Okay, let's dig into those medications a bit. What are the main players?
So you've got two main types, the chelating agents and zinc. Chelators, like D-penicillamine and trientine, actively remove copper that's already built up. Zinc acetate works differently. It stops your gut from absorbing copper from your food in the first place.
Ah, okay.
Often, trientine is preferred as the first-line chelator now, because it generally has fewer side effects than penicillamine used to have.
Gotcha. And are there general lifestyle things people with Wilson's need to keep in mind?
Definitely. Beyond the diet, it's important to have regular checks on liver and kidney function, blood clotting, blood counts. Patients should really avoid excessive alcohol and any drugs known to be potentially harmful to the liver. An annual eye check with the slit lamp is usually recommended to monitor the rings. And, critically, lifelong follow-up with a specialist center that knows Wilson's disease well is absolutely key for managing things long-term.
And pregnancy, you mentioned that needs careful handling.
It really does. It's a balancing act, controlling the mother's copper but keeping the baby safe. There's often caution around using chelators during pregnancy, so zinc acetate might be used more as it seems to have a better safety profile. Ideally, women plan their pregnancies, get copper levels well controlled beforehand. The aim is always to protect mom from copper toxicity while minimizing any risk to the baby. And just to clarify the risk, if both parents have Wilson's disease, the child has a 25% chance, a 1 in 4 risk, of inheriting it.
Right, 25%. Okay. And the liver transplant, when exactly does that come into play?
Transplant is usually for patients who develop that sudden acute liver failure or for those whose liver disease progresses to end stage despite the best medical treatment. A transplant essentially cures the Wilson's disease aspect because the new liver can excrete copper normally, so it stops the disease recurring. Outcomes are generally very good using either deceased donor or living donor livers.
And lastly, that deep brain stimulation you mentioned.
Yeah, DBS. That's a much more specialized invasive treatment. It might be an option for a very small, carefully chosen group of patients with severe neurological symptoms that just haven't responded well enough to all the medical therapies.
Yeah.
It involves putting electrodes into specific brain areas.
Okay, so putting it all together, what's the overall outlook? What's the prognosis for someone diagnosed with Wilson's?
Well, the good news is that with early diagnosis and consistent lifelong treatment, the prognosis is generally good. People can live relatively normal lives. However, if it's not treated, the disease progresses, and sadly, it can be fatal due to severe liver failure or irreversible neurological damage.
So catching it early is paramount.
Absolutely. Early treatment, especially before major organ damage sets in, can sometimes even reverse some neurological signs and make the Kaiser-Fleischer rings and sunflower cataracts disappear. Now, if liver or neurological disease is already well established, it might not be fully reversible, but lifelong treatment can still effectively control the progression. So patient education, making sure they understand why they need treatment for life, is just vital for a good outcome.
And any common complications people should be aware of, even with treatment.
Yeah, the main long-term risk, even with management, is the potential development or progression of cirrhosis of the liver. And cirrhosis itself carries risks, potentially leading to liver failure down the line. Interestingly, though, while cirrhosis from other causes often increases liver cancer risk significantly, liver cancer seems relatively uncommon in Wilson's disease patients, even those with cirrhosis.
Well, this has been an incredibly thorough deep dive into Wilson's disease. Thank you. It's clearly a complex condition, affects so many systems, but it really highlights that with early recognition and that consistent lifelong management, the outlook can actually be positive. It definitely underscores the importance, doesn't it, of considering even rare conditions when you're faced with unusual clusters of symptoms. And for those of you listening wanting to really solidify your understanding of Wilson's and other key medical topics for revision, do check out pasthemsra.com and freemsra.com. They're excellent resources. Maybe a final thought to leave everyone with. Considering the lifelong nature of treatment and the potential for serious complications, what do you think is the biggest ongoing challenge in managing rare genetic disorders like Wilson's day to day?